Hello friends, very good afternoon to all of you. Now we are approaching towards the last session of dermatology, and those who are still thinking that it is impossible to crack your you know FMG exam, then I can say that you can drop this IM and you can focus on the remaining words. Now this picture you can keep in your frame, in your brain, whenever you feel low. You just have to think that everything is possible. If I'm doing the hard work, if I'm focused towards my goal and the mission, then everything is possible. Nothing is impossible. You have to remove this word from your dictionary. And I hope you all must have tried the yesterday's telegram questions, and still some of you had made basic silly mistakes. So here our routine protocol that I'm going to discuss the questions what I had posted yesterday on telegram group. So you will be coming to know that how we have to approach and at what point we can make the mistakes. So we should realize our mistakes and we are not going to repeat these mistakes in future. This should be our main focus, that we should not be repeating these mistakes in the examination till exam. Whatever will be the test, whatever will be the exam, mock exam, any monthly test or any subject wise test, grand test, you can make the mistake provided that you are doing the analysis of the mistakes. Okay, so now coming to the question, a 25-year-old pregnant girl. Now here the keyword is that lady is or the girl is pregnant. This is a keyword. So as I said that solving these type of the questions, you should be able to identify the keywords. So the girl is pregnant, presented with a light brown pigmentation on the malar eminences. We know that during the pregnancy, the pigmentation appears. So, most likely diagnosis. So, we know that pregnancy and the pigmentation on the malar area, this is none other than chloisma of the pregnancy. Now, if they didn't mention that it is a pregnant, they say that is a brownish pigmentation on the malar area, then we have to do the differential diagnosis. Whether it has been increased with the sun exposure, then it is a melasma. And if it is with the telangiectasia and erythema, with the sparing of the nasolabial folds, then it will be your SLE. And if there is erythema and rosacea without sparing of the nasolabial fold, but it is increasing with the hot spicy food, then it will be becoming your rosacea. And melanoma, it is something different, which is a malignant tumor, the deposition of the more of the melanin pigment in that particular area, or the melanocyte proliferation. This could be benign to the malignant melanoma. So here the correct answer for this is, it is the chloisma of a pregnancy. Clear? Now, I hope nobody had made the mistake in this. Now, if a straightforward ask that what is this image is, you can say that this is an image of non-bullous impetigo or impetigo contagiosa. But here the question is that all are true for this given image. So we have to discuss the few important characteristics of this condition. This is a bullous impetigo. No, this is not a bullous. It is a non-bullous impetigo. It is a non-bullous impetigo. Yes. It is a golden yellow crust, yes, and this is streptococcal infection. So some of you had in confusion in the infection that whether it's in a streptococcal or the staphylococcal. But remember one point: if you are very sure that one thing is not, then other it may be the included in that. So what I just want to give you another hint for your examination, that if you are very sure then we have to go with the correct answer. Now the second is that when we are not very sure about the question and its answer, then we have to move with the the method of exclusion. Now exclusion means that we are very sure that this condition cannot be there, this condition cannot be there, this condition cannot be there, and if still you had a doubt, but you are very sure for the rest of the conditions, then you can go with that option. Because one positive aspect, we had in our examination, that till now we are not having the negative marking. So you are not supposed to leave any question, you have to attempt each and every question. Okay, so here we know that the given image, it is of not a bullous impetigo. If you are not sure about the streptococcal or staphylococcal variety, but you are very sure it is not a bullous, then the answer for this question is bullous impetigo, because they are asking all are true for the given image except. Clear? So here the correct answer is bullous impetigo. Now another is the moist lesion in the perineum with positive VDRL test. Now here they didn't mention too much in this question. They had seen the moist lesion in the perineum. It can be any lesion, but what a positive or the important keyword is that it is the VDRL test is positive. Now those who are not able to understand, please listen. The VDRL test, it is the test what we are doing for detecting the antibodies against the syphilis or Treponema pallidum organisms. So if they say that positive VDRL, it means something related to the syphilis. That is very clear. Now in the syphilis, the moist lesion in the perineum are none other than condyloma lata. Okay, so this is what we have to think. So what I say that why there is a need to do the practice of the questions, because within a minute, because 1 minute time is being given to us, and within a minute you have to read the question, you have to understand the question, and you have to think, correlate all those concepts, and then we have to come to the diagnosis. So we have to develop this practice, because we have to train our brain that should be reading the question, thinking, then giving the answer. You have to take that answer and go further. All these activities we have to do in a 1 minute. So condyloma acuminata, it is not, because here it is not a syphilitic infection. VDRL will not be a positive, and that here there is not a moist, it is a dry, rough, verrucous lesions are there. Condyloma lata, yes, this is a possibility. Herpes genitalis, again in the herpes we had a vesicles, grouped vesicles, painful, but VDRL test is not positive, and any of the above. So here the correct answer is condyloma lata. Now this is again a straightforward question. There is a urethral discharge, must be some sort of gonococcal urethritis. Now let us see the question, that all are true for the given image except. It's a gonococcal urethritis. Yes, this is a true answer. It's a non-gonococcal urethritis. No, because in the non-gonococcal we don't have the purulent discharge. Now severe dysuria, yes, we had the purulent discharge. Yes, so this is all the three true. So the answer for this question is non-gonococcal urethritis. Then this is another question, and might be the little bit difficult. So you could see some lesion, and if you can see carefully, some scales are there. So there is a scaly lesion present on the body. With this picture, it is not very clear that what body part is there. So the KOH mount of the given condition will show. Now we have to think little bit in this question. The copper penny bodies, now what you have to think, that copper penny bodies are in the chromoblastomycoma, and chromoblastomycoma, it is not looking like this, it is looking like a cauliflower growth. So this is out. Spaghetti meatball appearance, it is seen in pityriasis versicolor, and yes, pityriasis versicolor can be having a lesion, hyperpigmented lesion like this. So this could be the one possibility. Now, asteroid bodies are seen in sporotrichosis, As sporotrichosis, we have the sporotrichoid type of a lesion, like a lesion is spreading along with the lymphatics. So again, this is not the lesion. And ectothrix, it is seen in the tinea capitis. So again, this is not a gray patch or the black dot. So here the correct answer is spaghetti meatball appearance. So given image is of the pityriasis versicolor. So in this way, you have to do the little bit analysis of the question, and then we'll come to the correct diagnosis. Now we'll be discussing the few more topics. The topics what are left is a few miscellaneous diseases and some of the malignancies of the skin. So now we will be coming to the few miscellaneous. Miscellaneous means we are not supposed to study much in detail. These are the genetic disorders, these are the connective tissue disorders. Now you might have all studied in your pathology classes, but here we will be mainly focusing that what are the special skin manifestations of those underlying diseases. And few more are like ichthyosis. Then we'll discuss the few important points about the dermatitis. It could be the allergic or it could be the irritant dermatitis or the fixed drug eruptions we can have after giving the drugs. So these are the few important miscellaneous cutaneous manifestations. So now I'll be discussing few miscellaneous points, whether we can say the miscellaneous diseases. Miscellaneous diseases. Now first is, many of us have suffered the dandruff. And dandruff is nothing, it is a type of a fungal infection of the scalp. So it is seborrheic dermatitis. Seborrheic dermatitis. Now here the questions are asked. One is the image. That is again important point. They can give you this typical scales are there, as well as the agent has been asked. So the agent of a seborrheic dermatitis is, it is Malassezia furfur. It is Malassezia furfur. Now the clinical features are greasy, yellow colored scales. That is a very, very important characteristics. The greasy yellow scales. And they are present on seborrheic areas. They are present on the seborrheic areas. Now seborrheic areas we had already discussed, could be the scalp, it could be the forehead or the beard area, mustaches area. So these are the areas where we find that, like this is on the scalp, it is behind the ear, or it can be upper forehead or over the mustaches area or the beard area. So they are present on the seborrheic areas and they are itchy. So the greasy yellow scales on the seborrheic areas and they are itchy. Sometimes these scales are present on the scalp of an infant and they are giving like as in a cradle cap appearance. So in the infant, their appearance is like cradle cap. Now another important point is that in the adults, if these scalp are loose, then they are called as the dandruff. If these scalp are loose, this is called as a dandruff, and many times must have been experienced that if you are having the itching and we just scratch our scalp, then on the paper or on the sheet we find the scales falling from our head because these scales are loose. So in the adults, if the scales are loose, it is called as a dandruff. But if the scales are adherent, this is called as pityriasis amiantaceae. If the scales are adherent, it is pityriasis amiantaceae. The treatment is, as this is a fungal infection, so we have to apply the antifungal. Either we can give the local, many fungal anti-dandruff shampoos are available in the market, or we can have the systemic administration of the antifungal agents. So this is all about your seborrheic dermatitis. So here the point to remember that the type of the scale, that is a yellow greasy scales, it is because of the malassezia furfur, and they are present in the seborrheic areas. Now another condition is that we can have the dermatitis, and one is contact irritant dermatitis. Now you might have seen some the washermen or household maids or some ladies, when they are working in the kitchen, they are using the soap and they are having the scaling of the skin, especially in the fingers. एंड जैसे सडनली जब हम कपड़े धोना शुरू करते हैं और कोई पर्टिकुलर डिटर्जेंट हम यूज़ करते हैं, हमारे हाथ खराब हो जाते हैं बिकॉज दे आर एलर्जिक टू दैट पर्टिकुलर irritating material. Or many times you have seen the gardeners when they are handling the plants, और जो फूल वाले लोग होते हैं जो माला बनाते हैं, because they are constantly touching the flowers, and they say if you are using this type of particular flower and we are making the garlands, they are having this itching and this cracks in the skin. Sometimes they bleed also, and many times you have seen they are putting the band-aid or they're putting the tape, so that material it is not coming in the contact and they are not having the dermatitis. Or many times the household ladies, they are using the gloves because they have to work in the kitchen, they have to use the soap, so they are using the gloves to protect their skin to coming in contact of that irritant. So what are the points we have to remember is contact irritant dermatitis. You can see that on the area of the contact where it is that the skin is peeled off and it is erythematous allergic points are there. So this condition is non-immunological. It is a local irritation, but it is not an antigen antibody mediated. It is non-immunological. So the lesion is only at the point of contact, while in the allergic dermatitis the lesion may be beyond because it's because of antigen antibody reaction, but here it is lesion is only at the point of a contact. Now agents which can cause, either it could be the various detergent, alkali, or sometimes a hard soap, because they say hard soap may the alkali content or acidic content is high, so they are allergic to that. So agent could be the detergent, alkali, or the hard soap. And in this we had a two type of a clinical features. If it is a strong agent, strong alkali or the strong acid, then we are having the features like an acute eczema, and acute eczema it is oozing. So if it is a strong agent, we are having the symptoms like an acute eczema, like a oozing, edematous and oozing, उसमें से सीरस डिस्चार्ज होने लगता है, फ्लूइड डिस्चार्ज होता है. But if it is a weak agent, that it is giving a picture like a chronic eczema. Chronic eczema में chronic itching होता है, then lichenification and pigmentation. So chronic eczema like lichenification. So if it is a strong agent, it is giving an acute eczema like picture, and if it is a weak agent, it is giving like a chronic eczema like picture. Now you might have seen in those individuals who are having the chronic eczema, they are constantly itching, and in the foot or the hand, that area is having the darkish color, the hyperpigmented area, the prominent skin markings are there, thickened area, and that is called as lichenification changes are there. So this is all about his contact irritant dermatitis. Now another type is the contact allergic dermatitis, that is because of allergic reaction because of the immunological involvement. So this is your contact allergic dermatitis. And this is what I was discussing. It is your acute eczema picture. It is edematous, having the fluid or sometimes the bleeding happens. And this is your chronic eczema type picture when we are having the lichenification. Clear? Now, contact allergic dermatitis, it is immunological in origin. And this is due to the type 4 hypersensitivity reaction. It is due to the type 4 hypersensitivity reaction, and here the lesion is beyond the contact. Suppose the person is inhaling some agent and will have an asthma as well as can have the allergic rashes, because antigen antibody mediated reaction, it can happen throughout the body. So it is the lesion is beyond the contact also. And clinical features, we can have the acute picture also, or we can have a chronic eczema picture also. Acute eczema, same like it's a oozing a wound, and chronic, it is lichenified lesion. Now what can be the various agents which can cause? The most common metal is the nickel. Many times you might have seen in the labor or the workers, because of the inhaling the cement particles when they are working in the construction industry or the agency or construction site, then they are inhaling those cement particles. So it could be because of the cement inhalation, or many times it could be because of inhalation of some seeds through the respiratory tract, and that is called as a airborne contact dermatitis, ABCD. ABCD is airborne contact dermatitis. And most common agent responsible for phytodermatitis, most common agent of phytodermatitis. Phyto means plants. It is the Congress grass. So most common agent of phytodermatitis is the Congress grass. And you might have seen this, कहते हैं ना जंगली घास, कई बार सुना होगा. And when you're going in a forest or in some areas, and elder people, they say that don't touch this plant, खुजली हो जाएगा आपको, जंगली घास है, इसे मत छूना, खुजली हो जाएगा. And that is what this is looking like. You might have seen this plant so many times. So this is your Congress grass, and many times this could be an image based question also, that they ask that identify this. So this is your Congress grass, and it is causing the contact dermatitis and agent for the airborne contact dermatitis. So this is botanical name is, it is Parthenia. So Congress grass or Parthenia. And the agent which is present in this and responsible for the allergy in these grass, it is the sesquiterpene lactone. So this is the agent in this grass is sesquiterpene lactone. So commonest phytodermatitis agent is the Congress grass, which is also known as Parthenium, and the agent present in this is sesquiterpene lactone. And in all these allergic manifestations, we are doing the patch test. You must have seen some of your family members had undergone the patch test for detecting the allergy, and they come to know that they are allergic to these content, other the food stuff, and they say that you have to avoid that things. So this is the patch test, and patch test is positive for particular material. Now, as I think we had discussed this point also, here we have to take a reading twice. The first reading we are taking after 48 hours, and the second reading we are taking at 96 hours. And the reading preferred is at 96 hours. So this reading is preferred. So sometimes this could be an image based question, and they can identify what type of the test this is. This is the patch test. And for which condition we are using? We are using for the contact allergic dermatitis detection. And when we are taking the reading taken twice, but the preferred is after 96 hours. Okay. So this is about your contact allergic dermatitis. Then another condition we had, the atopic dermatitis. The point to remember about the atopic dermatitis is it is a chronic inflammatory disease with a relapse. Now this condition comes and goes off. So this cycle goes on. There is no permanent cure. It is coming, going, coming, going. Remission and relapses happen. So it's a chronic inflammatory disease with a relapse. Always there is a family history of allergy. And this is a very important clue they give, that a mother is having a history of an allergy, and the baby born 6 months old is again showing the symptoms of the allergic manifestation. What type of this dermatitis? It is an atopic dermatitis because it is running in the family. So there's a family history of allergy, and this is because of type 1 hypersensitivity reaction. It is because of the type 1 hypersensitivity reaction and there is an intense itching is there. Intense itching is there. Now itching hota you do on scratching, further there is a itching is there, so this continues. So there is intense itching is present. Now for the diagnosis of the atopic dermatitis, we had a criteria, and that is a Hannifin-Rutschkas criteria. Hannifin-Rutschkas criteria for diagnosis of atopic dermatitis. Now here we had major criterias and some minor criterias. Now for the diagnosis of the atopic dermatitis, we should be having 3 or more of the major criterias and the 3 or more of the minor criterias. Now what can be the major criterias? Family history, intense itching or pruritus, family history, intense itching or pruritus, remission and relapse, means it's a chronic condition where there's a remission and relapse happens, as well as the location of the symptoms. Now, in the infant, it can be seen on the face, flexors, or extensors. In the infants, it can be seen on the face, flexor, or the extensor surfaces. While in the children, it is only seen in the face and the flexor surfaces. While in adults, it is only seen on the flexor surface. So the distribution is classical. In the infants, the lesion can be on the face, flexor, and the extensor surface. In the children, it is only on the face and the flexor surface, while in the adults, it is only on the flexor surfaces. So these are the major criteria, and any three or more can be the diagnostic. Now there are a total of 23 of minor criteria. Total of 23 are the minor criteria, but you are not supposed to remember the all 23 of these minor criteria, but few you can remember. Like we can have a white dermographism, if you can remember, we had discussed the in urticaria, if you are just giving a scratch because of the vasoconstriction, we had a white skin, that is a white dermographism. We can have keratitis, we can have cataract, we can have madrosis, we can have keratoconus. There's so many conditions are there you're not supposed to remember. So just remember that diagnosis of the atopic dermatitis is done by Hannifin-Rajka's criteria. There could be the minor and the major criteria, so three or more of the major and the three or more of a minor criteria, and you have to remember the major criteria because these are given in that story, and you have to come to conclusion whether this is atopic dermatitis or the contact allergic dermatitis. Clear? So this is all about your atopic dermatitis. Next condition is fixed drug eruptions. Now, some of you must have noticed that those individuals who are having allergy to any drug, if they take, they are having the reddish patch on that particular fixed site, and after the multiple exposures, it is having the blackish discoloration, especially seen around the lip areas. So, fixed drug eruption it is because of the drug allergy. Now, drug allergy, if you are taking the drug for the first time, then immediately this doesn't happen. But if you are taking the second or the third time, that it happens within few hours. So first time intake, these symptoms they appears after 7 to 10 days. But a second time onwards, the symptoms can appear within half an hour to 8 hours. So always remember one point. That will be a very important success mantra in your clinical practice. Whenever you are giving any injectable medicine, always make sure that patient should remain with you for minimum half an hour, maybe the 1 hour. Any antibiotic if you are giving or anything you are giving parenterally IV. Because if the person is allergic to that and we don't know, the patient is not giving you the history, or the patient is developing maybe for the first time, as you are giving IV, quickly this is entering into the body, and within minutes the allergic manifestations they appear, and if the patient is in the hospital, you can manage. Otherwise, if the patient is leaving the hospital and patient is reaching home or going somewhere and suddenly collapse, and then you will be the big celebrity next day in the newspaper or on the TV channels that such and such doctor has given the injection and because of that the patient died. So if you don't want to become a celebrity within a few hours, always have a safe practice. Okay, so be very careful. And second point is that in your clinic, in your hospital, always keep the emergency medicine in a box ready. Always check whether the drugs are expired or they are within the normal duration, and if they are expired we have to replace them. And third point is that always keep the oxygen cylinder key at a right place. Many times the day staff is keeping the key to open the cylinder at a different place, and the night staff is not able to find. And you're having the 2-3 cylinders lying in the hospital, but you are not having the key to open the cylinder. So nowadays that patient are holding the mobile and anytime they can make the video. So in the medico legal practice, you know if you are following the steps properly and still if any complication happens, then you are not at a fault, because complication can happen, but if you are trying to manage properly, then you are not at a fault. But suppose if you had not managed, your cylinder is not working or you are not given the medicine, in that case you are at a fault. So be very careful. So fixed drug eruptions is that because the drug allergy. Now here we find that dusky red, erythematous, plaque are seen. Dusky red erythematous plaque are seen, like you can see this is the plaque, this is dusky red erythematous plaque is seen at the fixed site after drug intake. And what can be that fixed site? Either it is around the lip or it is on the tip of penis. So they are at a fixed site either around the lip or the tip of a penis, and they usually show the hyperpigmentation. They show the hyperpigmentation at that area, and this is due to delayed hypersensitivity reaction. And what are the common drugs which can cause the allergic manifestations? Although it can happen with any of the drug, but most common drugs are either it is anti-inflammatory, antibiotics, and most commonly is the tetracycline, sulfur drugs. So again, make a habit whenever you are writing any prescription, you have to ask the patient whether the patient is allergic to any drug. Many times the patient will tell you, if the patient are quite smart, the doctor, I am allergic to even paracetamol, some are allergic, or I am allergic to the brufen, I am allergic to the combifame, I am allergic to the Septran. So they will say, so you write in a bold letters or even mark with a highlighter that the patient is allergic on your prescription paper. Or if you ask and the patient doesn't say that or patient says that I am not having any known history, so you can write that no known history of drug allergy. Okay, so this is all about the fixed drug eruptions. So many times could be an image based question, and they can give you that after taking the para patient was having the abscess, and after doing an abscess drainage, the doctor had prescribed the anti-inflammatory medicine. After taking the anti-inflammatory medicine, after 48 hours, the patient is having the swelling and the red patch around the lips, and what could be this condition? So this is fixed drug eruptions, and the image is given. Okay, so this is about the fixed drug eruption. Now another condition is pyoderma gangrenosum. Pyoderma gangrenosum, although you might have studied in your surgical classes, this was a question asked in a last June exam also. So this condition is associated with inflammatory bowel diseases. This condition is associated with inflammatory bowel diseases, more with the ulcerative colitis than Crohn's disease. Now here we usually get an ulcer, and that ulcer is painful. Usually this is seen on the leg. Ulcer is painful, commonly seen in the leg, and this is having the undermined edges. So this is an ulcer which is commonly seen on the leg with the undermined edges, painful. So the question was asked in the June exam, and the image was given that the patient is presenting with this given ulcer and associated with some intestinal disturbances. What could be the possibility that could be associated with the ulcerative colitis? Now, please message me what are the two other conditions where we can find the undermined edge in the ulcer. We had discussed already. What are the two other conditions where we may find the undermined edge in ulcer? Please message me. Okay, the one is chancroid. Another is tuberculosis. Very good, very good. So we are having in the tubercular ulcers as well as the chancroid. Very good. Now in the syphilis, we don't have the undermined edges. In the syphilis, we are having the elevated edges. Okay. In the chancroid and the tuberculosis, we are having, in the psoriasis, dear, we don't have the ulcerations. Okay. We had a plaque. So other conditions where we had an undermined edge is in the ulcer is the tubercular ulcer as chancroid. Okay. So this is about your pyoderma gangrenosum. Now another condition is ichthyosis. Now the point to remember about the ichthyosis, it is again a genetic disease, and where there is defect in filaggrin protein. It is a genetic disorder where there is defect in filaggrin protein, and this filaggrin protein is holding the keratin filaments, so there may be some disturbances. And very important image based question, that this type of the image is given and they say that identify the disease. Here the scales are like a fish like scales are there, so this condition is ichthyosis. So here fish like scales are seen, so very important, the scales are fish like. Now most common ichthyosis is ichthyosis vulgaris. Most common ichthyosis is ichthyosis vulgaris. As I said, that vulgaris means the most common. Acne vulgaris, ichthyosis vulgaris, lupus vulgaris. Now please see this image. Now here the baby is born with a membrane all around, and this is called as collodion baby. collodion baby. Here the baby is born with a membrane, and this condition is seen in lamellar type of ichthyosis. Lamellar ichthyosis. So collodion baby is the baby born with a membrane, and this is seen in lamellar ichthyosis. Now another see this image, that this is an advanced stage of collodion baby, where the membrane is very thick, showing the fissures like an armor suit. एंड इतने ज़्यादा फिशर्स होते हैं, क्रैक बिल्कुल एक टाइट मेम्ब्रेन से कवर्ड होता है कि ना तो आईलिड्स क्लोज हो सकते, ना माउथ क्लोज हो सकता, एंड मैनी टाइम्स द बेबी dies because it is a genetic disorder. We cannot do anything. Like you can remember, just like if you had applied a face pack or anything, or you had applied a henna on your hair, once they dry it becomes very hard. Or face pack, if you had applied a face pack and it is drying, and if you try to open your mouth or try to open your eyes, it is getting cracked. Same like here, the membrane is very thick. So this is an extreme form or advanced form of collodion baby. It is called as Harlequin a baby. Harlequin baby. Harlequin baby is nothing but it is the advanced stage of collodion baby. Advanced stage of the collodion baby, and here the body covered with thick membrane with fissure like armor. So this is an Harlequin baby. So the point to remember in ichthyosis, that the image of the Harlequin baby. The collodion baby is seen in which type of ichthyosis? It is seen in the lamellar ichthyosis. It is not in the ichthyosis vulgaris, but it is seen in lamellar ichthyosis. And most common type of ichthyosis is the ichthyosis vulgaris, and the type of the scale we had, it is the fish-like scale. This is about your ichthyosis. Now another condition is tuberous sclerosis complex. Tuberous sclerosis complex. It is also known as Borneville disease or Epiloi disease. Borneville disease or Epiloi disease. Now we are having the triad of symptoms in the tuberous sclerosis, and we can remember with this Epiloi disease as epi, low IQ and A. The three main manifestations we had, the first is epilepsy. So tuberous sclerosis complex. Complex means a group of the disorders. It is also known as the Borneville disease or Epiloi disease. That is epilepsy, baby born with a low IQ, and we are having the angiofibroma. So these are the triad of manifestations. Now if we talk about what are the skin manifestations in the tuberous sclerosis complex. So this is in general the three manifestations of the body. that is epilepsy, low IQ, and angiofibroma. Now, if we talk about the skin manifestations, so skin manifestations and its diagnostic criteria. Skin manifestations in the tuberous sclerosis complex. Now this is angiofibroma. Angiofibroma is seen in almost 90% of the individuals. That's the most common. And if I zoom this image, we may find the erythematous telangiectatic lesions are seen throughout the face. So this is angiofibroma. Now another very important is this macule, and this is ash leaf macule. This is again a very important point, that ash leaf macule is seen in which disease? It is seen in tuberous sclerosis complex. Which is the most common manifestation on the skin is angiofibroma. Now what is an ash leaf macule? The point to remember, it is the hypopigmented macule. It is the hypopigmented lesion. And one more point, if you can remember, we had discussed while doing the wood lamp examination, all these hypopigmented lesions, they become prominent. So even in a leprosy, if you're not able to see any pigment, in the tuberous sclerosis, you have to look with the wood lamp, any ash leaf macule is there. So prominent with a wood lamp examination. Prominent with the wood lamp examination. And their shape is like this. It is pointed at one end and curve at another end. This is the shape. So ash leaf macule. So remember that they are prominent with a wood lamp examination. Now we can have another feature. If you can see, this is a patch is there, especially on the lumbosacral area, and if you touch it, is very thick like a pig skin, and this is called as a shagreen patch. Shagreen patch. This is also a diagnostic point of tuberous sclerosis, and this is leathery patch on lumbosacral area. Leathery patch on lumbosacral area. Another is, if you see, this is the normal nails, and from the nail folds we are having these fibromatous lesion appearing, and this is Conin tumors. So another diagnostic point in the tuberous sclerosis we had is the Conin tumors, and these are subungual fibromas. So these are the important points which are diagnostic of tuberous sclerosis. So they can give you a story like a newborn is born with having a epilepsy, after some time detected having a low IQ and had a Conin tumors. What could be the possible diagnosis? So Conin tumors or the shagreen patch or the ash leaf macule or the angiofibromas, they all are the skin manifestations of tuberous sclerosis. Now another condition, I think we had discussed the 3-4 important points yesterday, that is the neurofibromatosis, when we were discussing the pigmentary lesions, cafe macules. It is just a repetition because many times the questions has been asked. So neurofibromatosis, the clinical features are, we find these are the multiple rounded nodules, soft multiple rounded nodules are there, and these are neurofibromas. So we are talking about the neurofibromatosis type 1. So the neurofibromatosis type 1, we had neurofibromas, and we had discussed the one sign related to neurofibroma. Please message me what was that sign. And I'll give you a hint. When we press all these neurofibromas, they go inside. What is that sign called as? When we press these neurofibromas, they all go inside. What is that sign called as? Great. It is the buttonhole sign. Very good. So we are having the multiple neurofibromas and they are showing the buttonhole sign. Great. Excellent. And in this way we have to remember. Now we are having the multiple hyperpigmented patch is there on the body, and that is cafe or let macule. These are the hyperpigmented patch, and we had already written that point that more 6 or more number should be there, and more than 5 millimeters in the pre-pubertal, more than 15 millimeter in the pubertal. We had written these points earlier. So cafe latte macules. Now the third is, we had seen that there is an axillary freckling. The pigmentation is in the axilla, and what that sign called as, please message me. Axillary freckling. What that sign was. So third condition was axillary freckling or freckle. What was that sign is? Excellent. It is the crow sign. Excellent. So these are the three important features, that is, we may have the neurofibromas, which is having the buttonhole sign, cafe latte macule, and axillary freckles. Now, if we suspect, please listen carefully, if we suspect that the person is having the neurofibromatosis 1 based on these criteria, the most important question what has been asked is what to do next, because we have to confirm further by locating the pigmentary lesions in the iris, because we are having the specific nodules in the iris, and that is called as leash iris nodule, and they are detected by slit lamp examination of the eyes. So very commonly they give you that a person is having a cafe latte macule with the axillary freckling and the neurofibromas, what examination you will prefer next. So it is not a wood lamp. Please remember, it is the slit lamp examination of the eye to detect the leash iris nodule. So the next feature what we are finding in the neurofibromatosis 1 is the leash iris nodule. These are the pigmentary hematomas. They are present on the iris. They are the pigmentary hematomas. They are present in the iris. The two or more are diagnostic. If the two or more nodules or the hematomas are present, they are diagnostic. And you might be worried that whether they are affecting your vision or not. So there is no effect on a vision. They are not affecting the vision, and they are diagnosed by slit lamp examination. So the important point is the slit lamp examination to identify the leash iris nodule to confirm neurofibromatosis of 1. Okay, And we had already discussed that in the neurofibromatosis 2, we had acoustic schwannoma, that is a tumor related to the acoustic nerve. So this is all about your neurofibromatosis. Okay, so point to remember that we are having this neurofibromas giving a buttonhole sign, cephalotomacule, axillary freckles, crow's sign, and the lesh iris nodule detected by a slit lamp examination of the eye. Now another condition in discoid type of lupus erythematosus is the carpet tack sign. Carpet tack sign or the cat tongue sign. Carpet tack sign or the cat tongue sign. This is seen in discoid lupus erythematosus. Discoid type of LE. Now please understand what it is. Now as you had seen, if you had seen the tongue of cat, it is having the projections like this. This is just to catch the prey. Or if you are turning back your carpet, we just put some tacking material, so it is fitting the ground, it is not moving. So actually what happens in this condition, over the skin we are getting the thick scales, and these scales are having the projections, and these projections are blocking the pilosebaceous units. So we are having the thick scales and which are having the projections of blocking the pilosebaceous unit. And when we remove these scales, like this, suppose if we had removed this scale and we see that they are giving us these are the projections which are blocking the pilosebaceous unit. And this is appearance is like a cat tongue or the carpet tack appearance. Okay. So the point to remember is that this is seen in the discoid lupus erythematosus. So they can give you the image and they can ask that in which disease it is seen. And here the reason is that thick scales, they are blocking the pilosebaceous unit. The thick scales, they are blocking the pilosebaceous units, and on removal looks like cat tongue. So these are the points what you have to remember. So this is the most important, that in which condition it is seen. It is seen in the discoid lupus erythematosus. Okay. In the systemic lupus erythematosus, only the one feature we have to remember, that we may find the malar rash or the butterfly rash. And this is the image what we had already seen. So this is clear, the carpet tack sign or the cat tongue sign in the discoid lupus erythematosus. Now another very commonly asked image is, this is the telangiectatic rash what we may find on the malar eminence. So this is your butterfly rash. So butterfly rash, the point to remember about this is that it is seen in acute stage of SLE. It is seen in acute stage of SLE. Here we are having the erythematous telangiectatic rash on malar eminence. We are having the erythematous telangiectatic rash on the malar eminence, but the important point is that there is nasolabial sparing. Sparing of nasolabial area. Now please message me in which condition we had the erythematous telangiectatic rash involving the nasolabial area. There is no sparing of the nasolabial area, we are involving that area. In which condition we had? Erythematous है, telangiectatic है, same like a malar area, but we are not having the sparing of the nasolabial area. It is rosacea. Excellent. It is not the pityriasis rosacea, it is only the rosacea. Excellent. So that condition is a rosacea. Very good, very good. Okay. So this is about the butterfly rash. Now another condition we had is dermatomyositis. Oh, sorry. I'll write on a, just give me a minute. So the next condition is dermatomyositis. Dermatomyositis. Now here we usually have the erythematous lesions around the ocular area, and this is called as heliotrope erythema. Heliotrope erythema around the eyes. Another diagnostic point is that we are having the Gottron papule. Gottron papule means that we are having the erythematous papules over the metacarpophalangeal and the interphalangeal joints. If you please listen carefully, if we had only the single papule, it becomes a Gottron papule. And if you had a multiple papules, it becomes a Gottron sign. Okay. So Gottron papule means that we are having the erythematous papule over metacarpophalangeal or interphalangeal joint. Erythematous papule over the metacarpophalangeal or the interphalangeal joint, and if it is multiple papules are present, then it is called as Gottron sign. So no confusion, the Gottron papule or the Gottron sign. If it is single papule, it is a Gottron papule. If it is multiple, then it is a Gottron sign. Now we can have this erythematous lesion on the V of the neck, on the sun exposed area, and this is called as the V sign. A V sign means erythematous lesion on the V of the neck. Or we can have the erythematous lesion on the sides of the thigh, and this is the area where the army people they put their gun. So this is known as holster sign. Holster sign, when we had a erythematous lesion on the side of the thigh, so that is holster sign. Or we can have this erythematous lesion on the back where we usually wear shawl, so this is called as the shawl sign. So these are a few features of dermatomyositis. So I'll just repeat again. So in the dermatomyositis, we may find the shawl sign, that is erythema on the back, holster sign on the side of the thigh, or the V sign on the V of the neck, or we can have the Gottron papule or the Gottron sign or the heliotropic erythema. So these are the features of dermatomyositis. So these are a few important systemic diseases and their skin manifestations. Now we'll be discussing a few important points about the skin tumors. Now they could be the benign tumors or the malignant tumors. Okay, before that, I'll just scroll all these points because many a times you might be having the confusion. So quickly, I'll revise all the slides because these are the important image-based questions that we should remember. In the seborrheic dermatitis, malassezia furfur, the greasy yellow scales in the seborrheic areas, the loose scales are a dandruff. The contact irritant dermatitis, it is a local area of the contact and it is not immunological, while the allergic dermatitis, it is because of the type 4 hypersensitivity reaction and it is immunological. The lesion is beyond the area of the contact. The most common metal is the nickel. And it is not the most common of all the allergies. The most common metal, which is in the artificial jewelry, it is the nickel, or it can be because of the cement inhalation, and it could be the airborne contact dermatitis. And the most common agent of the phytodermatitis is the Congress grass or Parthenium grass, which is having the sesquiterpene lactone, and the patch test is positive, preferred after the 96 hours. In the atopic dermatitis, the major criteria is important. The Hennepin-Azachkas criteria, that is a strong family history. There is a presence of itching, remission and relapses are there, and the location. And in the adults, it is mainly present on the flexor surfaces, while children it is present on both the flexor surface, face, as well as the extensors in the infants, while in the children it is on the face and flexors only. Now, fixed drug eruptions, that erythematous plaque at a fixed site, it may show the hyperpigmentation later on, and this is because of delayed hypersensitivity reaction present on the lip and the tip of the penis, and always there is a history of the drug intake is there. Now, pyoderma gangrenosum, it is having the undermined edges and it is associated with the inflammatory bowel diseases. Okay, then we are having ichthyosis. The most common is the ichthyosis vulgaris, having the fish-like scales, the collodion baby, and it is in the lamellar ichthyosis, and the severe form is the harlequin baby. Then we had the tuberous sclerosis complex and pride of epilepsy, a low IQ, and angiofibroma, which is seen in 90% of the individuals, along with the ash leaf macule, Shangreen patch is there, and the Conan tumors are there. Okay, the neurofibromatosis, we can have the neurofibromas, capillary macules, axillary freckling, and the Leschar's nodule, and confirmed via the slit lamp examination. Then we had carpet deck sign in the discoid lupus erythematosus. Then butterfly rash in the acute SLE. We are having this discoid butterfly, a type of rash with the sparing of the nasolabial folds, and we are having dermatomyositis, halotropic rash or erythema, Gotron papule, Gotron sign, the V sign, Scholl sign, and the Holster sign. Now we'll be discussing the few important points about the various tumors of the skin. And in the tumors, the commonly asked questions is with the malignant melanoma or the squamous cell carcinoma or the basal cell carcinoma differences. Or we can have some malignancies like Langerhans cell histiocytosis or cutaneous T cell lymphoma, and some benign lesions as Salmon patch, or we can have port wine strain. So, a few points about skin tumors. So, nevis and skin tumors. Now, first is Salmon patch. Now, you may find this vascular malformations usually present on the forehead or the neck in the newborn baby, but this disappears. So the could be your image based question, and the point to remember about the Salmon patch is it is the vascular malformation seen in children or rather you can say that infants, newborn babies, seen in the infant. Site is, it is seen on the forehead or neck, and they usually disappear by a 1 to 3 year of the age. But the port wine strains, they usually persist and they are increasing with the age. So this is the Salmon patch. The next is port wine stain, and again this could be an image based question, that here you find that erythematous lesions are seen along with the nerves like a trigeminal nerve. Like in ophthalmic herpes zoster, we are having these lesions. The nevus of ota, we had the pigmentary lesions along with the trigeminal nerve, and here we are having the vascular malformations. So port wine stain is nothing, but here we are having the vascular malformations along with trigeminal nerve. Vascular malformations along with the trigeminal nerve, and this is increasing with age. That is the important point, and it is increasing with the age. So there is either we have to block that vessels by some coagulating agent, or this stain will remain throughout the life. And I have seen so many individuals, they are using the face concealer or different type of cosmetics or the foundation to just cover this color. Now, if it is associated with a systemic manifestation, it is part of one syndrome, that is the Sturge-Weber syndrome. Now, Sturge-Weber syndrome, it includes Sturge-Weber syndrome. This includes the port wine stain, presence of seizures because of CNS vascular malformations. Sturge-Weber syndrome is associated with the port wine stain, the vascular malformations of the CNS causing seizures, and a glaucoma. So this is about your Sturge-Weber syndrome and port wine stain. Okay. Then another important condition and questions has been asked from that is mycosis fungoides. Mycosis fungoides. Now this is cutaneous T cell lymphoma. Cutaneous T cell lymphoma. Now question commonly asked is what type of the abscesses are seen in mycosis fungoides? And this is portrait microabscess. Portrait microabscesses are seen, and these are nothing but the lymphocytes in stratum spinosum. Lymphocytes in the stratum spinosum, and these are the portrait microabscesses. The lymphocytes are seen in the stratum spinosum. Okay, so question is that portrait microabscesses are seen in which condition? It is in mycosis fungoides. Now please message me, Monroe's microabscesses are seen in which condition? Please message me, Monroe's microabscesses are seen in which condition? Monroe's microabscesses are seen in which condition? Great. So Monroe's microabscesses are seen in psoriasis and they are in the stratum corneum, while the portrait microabscesses are seen in mycosis fungoides and they are present in the stratum spinosum. Now, we had a one special type of the cells in the blood, that is Sézary cell. Sézary cell, you could see this image. This is the Sézary cell, and these are nothing but they are abnormal lymphocytes which are having this cerebriform nucleus, and these are called as Sézary cell. So what these Sézary cells are? These Sézary cells are nothing, these are the abnormal lymphocytes in the blood with cerebriform nucleus. So Sézary cells are seen in mycosis fungoides, portrait microabscesses are seen in mycosis fungoides. Now we had one Sézary syndrome. And what are the components of the Sézary syndrome? We had the Sézary cell in the blood. This is along with lymphadenopathy, and we are having erythematous lesions. So Sézary syndrome, when we had a Sézary cell in the blood, lymphadenopathy and the erythematous lesions. Now what type of erythematous lesions we can have? If you see this image, we may have these erythematous plaque-like lesions throughout the body, especially in the upper and the lower limbs. And if they are along with the Sézary cell in the blood, or we may find the portrait microabscesses in the skin biopsy, then the diagnosis is confirmed for mycosis fungoides. So the point to remember is that it is a cutaneous T cell lymphoma where we are having the portrait microabscesses, the Sézary cells are there, and the Sézary syndrome is also there. Clear? So this is your mycosis fungoides. Now another condition we had where we can have the different type of melanomas. Now, how we can differentiate between the benign and malignant melanoma? So I'll show you the image and then I will come to the point. In the melanoma, please look at these images. That this is your benign melanoma and this is your malignant melanoma. Now we had the symmetrical appearance in the benign while it is asymmetrical appearance in the malignant. Then borders are regular while in the malignant the borders are irregular. Then uniform color in the benign and it is of a multiple colors in the malignant. A smaller than a 6 millimeter size is benign, if it's a bigger one is malignant, and if it is rapidly progressing it is malignant, and if it is slowly increasing it is benign. So now we will be writing the few important points differentiating the benign and malignant melanomas. Melanoma. What are the differentiating features between benign and malignant? So many times they will give you the image and they'll ask that what this image is. So you can differentiate with, remember, by mnemonic A, B, C, D, E. Now A is the appearance, B are the border, C is the color, D is the diameter, and E is the evolution. So appearance, border, color, diameter, and evolution. Now appearance is regular and malignant में it is irregular appearance. Borders are well defined in benign, while in malignant it is ill defined, irregular. Color is uniform in benign. It is of the variable color in malignant. Diameter is less than 6 millimeter is benign. More than 6 millimeter is malignant. Evolution is slow growing and malignant is the rapidly growing. So these are the points what you have to remember, because you have to differentiate the given image based on these features. So this is the difference in the benign and malignant melanoma. Now another very commonly asked image is how to differentiate between the squamous and the basal cell carcinoma of the skin. So I'll show you again the images and then we'll discuss the differentiating points. This is how the squamous cell carcinoma and the basal cell carcinoma. Now first understand the basic pathology, although they never ask, but we have to understand. The basal cell carcinomas are basically the carcinoma of the basal cell layer of the skin. So when these basal cell layers are malignant, they usually spread downward or little bit upward. They usually don't spread laterally. So here we are having the localized induration, localized spread, and we are not having the widespread generalized malignant lesions. Okay, and here the edges are usually the smooth and rolled inside. While the squamous cell carcinoma can be of the malignancy of the any of the keratinocyte cell, and this can be seen in any part of the body. While one more point in the basal cell carcinoma, it is commonly seen on the photo-exposed areas. Those are exposed to the sun. In that area, there is a damage to the basal cells by the ultraviolet rays, and it is converting into the malignant cells. Okay, so these are the differentiating points, and based on that, we will be identifying the image. And here in the squamous cell, they are growing like an everted edges, and sometimes they grow like a cauliflower-like appearance. So now we'll write the differentiating points. The cause for the squamous cell, it is on any of the damaged skin. Any skin which can be damaged by any disease or any lesion can stimulate the squamous cell carcinoma, while the basal cell carcinoma is commonly seen in the photo damaged skin. That area which has been damaged by the sunlights only. Now, mucosal lesions may be present in the squamous cell, but as the basal cell is localized, so mucosal lesions are absent. Okay, but you can put a one point is in the squamous cell basal cell carcinoma. Sorry, it is the most common skin tumor. Most common skin tumor or the skin malignancy is the basal cell carcinoma. Now, clinical features are in the squamous cell, the edges are everted, cauliflower-like. Now, edges are everted and looking like a cauliflower, while in basal cell, they are rolled inside, or the rolled up. You could see that they are rolled up inside, beaded or waxy. So the edges in the basal cell, they are the rolled up, beaded or waxy. Now, squamous cell carcinoma lesions can be seen in any body part because skin damage can be seen in any body part because of any reason, while the basal cell carcinoma commonly seen in the sun exposed areas. Okay. Now, squamous cell are having the highly indurated base. Induration is plus plus plus, while mild induration may be seen in squamous cell, basal cell carcinoma. Squamous cell carcinomas are highly indurated. Squamous cell carcinoma, they are proliferating at a little bit faster rate. So rate of growth may be slow to rapid. But basal cell, they are only slow growing tumors. As there is a widespread is seen in the squamous cell, so lymphadenopathies are present, while basal cell are localized, so there is no lymphadenopathy. Obviously, the visceral metastasis can be seen in the squamous cell carcinomas, while it is not seen in the basal cell carcinomas. So these are the differentiating points, that visceral metastasis is present in the squamous cell with lymphadenopathy, rapidly proliferating, highly indurated, can be seen on the any body part, and usually the edges are everted and cauliflower-like. Mucosal lesions are seen and seen on the damaged skin. Now the last is in this tumor group is the Langerhans cell histiocytosis, when there is an increased number of the Langerhans cells are there. So before going to that, please message me that Langerhans cells are present in which layer of the skin. Langerhans cells are present in which layer of skin. It is in the stratum corneum, stratum granulosum, stratum spinosum, or the base. Langerhans cells are present in which layer? Yes, I know. It is non-keratinocytes. I'm asking three layers: the stratum corneum, stratum spinosum, or stratum granulosum. In which layer it is present? Great. It is stratum spinosum. Okay. Those who are writing as a present in the dermis, no, this is not present in the dermis. In the dermis, we had the fibroblast cells, mast cells, and macrophages, and these are the Langerhans cells, which are antigen presenting cells, and they are present in the stratum spinosum. Okay. Now one more question, that there is a special type of the granules are present in these Langerhans cells. What is the shape of those granules? What is the shape of those granules in the Langerhans cell? It is like some playing object. Great. It is the bulbic granules, which are like a tennis racket. Excellent. So now coming to the Langerhans and histiocytosis, the point to remember here is, here there is increase in the Langerhans cells. Excellent, excellent. So bulbic granules present in the Langerhans cells, looking like a tennis racket. So here there is an increase in the Langerhans cells, and the markers of the Langerhans cells are CD1A, CD207, or S100. So these are the markers of these cells. And in these conditions, if you could see that we may find purpuric scaly lesions, they are present. Here they are looking like on a body, but mainly they are present on the seborrheic areas. Now in the children they are widespread. जैसे जैसे age कम होता चला जाता है, इनका severity कम होता चला जाता है. Okay, so these are the purpuric greasy yellow brown scaly papules. They are purpuric greasy yellow brown scaly papules, and they are present on seborrheic distribution mainly. Mainly they are present on the seborrheic distribution. So here there is an increase in the Langerhans cells. Now markers are there, and the most important marker is the CD207. We are having the purplish brownish scaly papules mainly on the seborrheic distribution. And depending upon the age, as I said that younger age में ज़्यादा damage होता है, and you know, as the age increases the damage is less. So either it is affecting the single or the multiple organs. We are having the osteolytic bone lesions, and the bone which is affected most common is the clavicle. We are having the osteolytic bone lesions, and the most common bone affected is the clavicle, or we can have in the skull. And in the skull is the temporoparietal area. So most common bone showing the osteolytic skin lesions is the clavicle. It can be seen in the skull also, especially in the temporoparietal bone, or may be associated with the diabetes insipidus. So this is about the Langerhans and histiocytosis. So we have to remember that multiple organ involvement osteolytic lesions may be associated with the diabetes insipidus. So these are all about your various skin tumors. Okay. Now the last 4-5 slides, that we are having some cutaneous manifestations of few internal diseases. Although the disease is internal, but we are having the cutaneous manifestations, like in pellagra we are having the dermatitis, like in ectodermatitis enteropathy, zinc deficiency we are having the rashes, like in lipid metabolic disorders we are having the xanthomas. So few cutaneous manifestations of the internal diseases. Cutaneous manifestations of internal diseases. These are mainly the image-based questions. Although you might have seen these images in your respected disease discussion in the different subjects, but here this is simply a revision of all those points. Now this image I think we had already seen yesterday, that this is Acanthosis nigricans. Here we may find the velvety hyperpigmented patch. So simply write one point, that this is seen in obesity and diabetes mellitus. And we had already written the 2-3 more points separately. So this is seen in obesity and diabetes mellitus. Commonly asked image that identify this is Acanthosis nigricans. Leathery patch is there. Now another condition which is seen in the defective lipid metabolism is xanthomas. And this is again, you may find the lipid deposition especially on the medial end of the eyelid. So this is a xanthoma, and what this is, that it is in the defective lipid metabolism and yellowish deposits on the medial end of eyelid. Yellowish deposits on the medial end of eyelids, and many times you might have seen that they say cholesterol ज़्यादा है, cholesterol deposits हो गए हैं, and they might be taking certain drugs to lower down the cholesterol, or they are trying to improve their lipid profile. In malnutrition, we can have the marasmic baby or the kwashiorkor baby. These images you might have seen in your pediatric classes also. In the marasmus, it is looking like a monkey face. खाली face दिखता है, all the body is almost gone because there is hyperproteinemia as well as the low calorie count. Carbohydrate भी कम होता है, protein भी कम होता है. So when they are not having the carbohydrates, the proteins are providing, or this muscles are providing the energy. That's why they are having the muscle loss also. So in the marasmus, we had a monkey face, while in the kwashiorkor, there is only the hyperproteinemia. That's why the edema happens. So this was another image was given in a last exam, and they asked that what this condition is. This is kwashiorkor, and in the kwashiorkor we can see the distended belly, and there is a rough hair, and sometimes in the hair you can find a flex sign, means a different color hair are seen. So the points you can write in the kwashiorkor, that edematous body is there, and flex sign in hair, and this is all because of malnutrition, and there is low protein. Energy is normal. Protein is low, but energy is normal. While in marasmus, you can say the protein is low as well as energy is also low. So this is about your kwashiorkor and marasmus. Now in the vitamin A deficiency, so just remember here is the flex sign and a monkey face in marasmus. Now we can have the bitot spots in the eyes in the vitamin A deficiency. This is the foamy spots are seen on conjunctiva. So in the vitamin A deficiency, we can have the bitot spot, and we all know that first symptom is night blindness. The first sign is conjunctival dryness, but this is the most important clinical sign. So the bitot spot is most important clinical sign because conjunctival dryness it is not able to appreciate, but these are clearly visible. And we all know that advanced stage of vitamin A deficiency can lead to the keratomalacia. And one more question we usually discuss in community medicine is the most specific feature of vitamin A deficiency is the serum retinol level. So most important clinical sign is the bitot spot, and the most specific feature of vitamin A deficiency is the serum retinol level estimation. Then another condition is, this is again a very commonly asked image, asked in so many exams, whether it could be FMG exam or the PG exam or NSET exam, is the niacin deficiency mein we are having the pellagra, and we know the pellagra, the diarrhea, dementia, dermatitis. So diarrhea is an intestinal manifestation, dementia is a mental manifestation, and dermatitis is a skin manifestation. So here we are having the pigmentation on the photo exposed areas, especially on the neck and the hands. So this is a part of a pellagra. So niacin deficiency mein we had a skin manifestations of pellagra, and very important sign this is, that is castle neck appearance. Castle neck appearance, or we can have the lesions on the photo exposed area like neck or arms and hand. So niacin deficiency, that is the pellagra, we had a skin manifestations like a castle neck appearance or the lesions in the photo exposed area like a neck, arm and hand. Now another condition where the skin becomes very rough, dry, like toad skin, and this is in vitamin A and vitamin A and essential folic acid, essential fatty acid deficiency, and that is phrenoderma. So here the skin is becoming rough, small papular lesions are seen. This is phrenoderma. So phrenoderma is nothing but it's the rough scaly skin like a frog skin, and this is seen in a vitamin A deficiency or essential fatty acid deficiency. So vitamin A deficiency or the essential fatty acid deficiency, we see the Franoderma. The last image, again very commonly asked in the examination, is because of zinc deficiency. And here we had the erythematous lesions around the around the orifices, could be the oral or the genital area, as well as on the hand. So this condition is called as acrodermatitis enteropathica. Acro means hand, dermatitis means some skin lesions, and this is because of enteropathy means intestinal problems. So this condition is seen in zinc deficiency. And what was the reason of the zinc deficiency? It is not deficient in the diet. The diet is having the normal zinc, but this is because of the defective zinc absorption. It is due to the defective zinc absorption from intestine. It is due to the defective zinc absorption from intestine. And there is a genetic defect that they are not able to absorb the zinc. And in this condition, we are finding periorificial erythematous lesions. Periorificial erythematous lesions, as you could see that on the face, around the oral cavity, around the vaginal cavity or the anal cavity, or on the hands also. So this is acrodermatitis enteropathica. Don't confuse this image to the hand foot mouth disease. Now in the hand foot mouth disease, we may find the typical vesicles or the papules are seen. Here we don't find any vesicles or the papules. We are finding just a erythematous rash is there. Okay. Or don't confuse with the slap cheek appearance where we had only in the cheek the erythematous lesion is there. It is not around the oral cavity, or it is not around the perineal cavity. Okay, so these are the a few important cutaneous manifestations of systemic disorders. So in this way, we had completed our syllabus of dermatology. Now, if you wish, we can discuss the questions of past 2-3 exams. I had collected the questions of dermatology from the previous year questions, and if you say that we will discuss. So please let me know if you want to discuss or not. So please let me know. Okay, yes. So everybody wants to discuss. So what I can do, just take a 10 minutes break here. Just relax and just try to conceptualize the content what we had discussed in the past 3-4 lectures, and after a break of 10 minutes we'll discuss the questions, and meanwhile if you had a doubt, we will be solving that thing. Okay, so we'll have a 10 minutes break. The time by my watch is 4:55. So we'll be starting this class at 5:05, and then we'll be discussing the questions. Okay, so meanwhile if you had any doubt, you can message me. So now we are discussing uh, the questions. The first we'll start the questions of uh, June exam. So these are may not be the exact questions because whatever the information we are collecting from the students, we are framing the question. The option may not be exactly the same, but they are almost near to what the question was asked. So a child presented with a patch of hair loss with exclamation mark. This question we had discussed day before yesterday in the Telegram group also. And what is the diagnosis? So here no confusion as the straight forward the keyword that it is a loss with the exclamation mark. So as I said that we should try to identify the keywords. Okay. So here the answer is none other than alopecia areata. Now, why not a tinea capitis? Because in the tinea capitis, we do not now have an exclamation mark. Trichotillomania, it is a psychological disorder and a person is plucking the hair. So variable length of the hair loss is seen and we don't have an exclamation mark. And telogen effluvium, the whole of the hair will be affected because here the anagen phase is converting into the telogen phase and after 3 months of that action, this will be going. Okay, so yes, all are answering me. It is good. It is alopecia areata. A patient gardener by occupation presented with a foot lesion with the discharging granule. I don't know why all these question mark are there in place of numbering. Might be some problem while transferring the file. No problem. A patient who is gardener by the occupation presented with the foot lesion with the discharging granules and the sinuses. So wherever we had a lesion in the foot, like a cauliflower with the discharging granule and the sinuses. Okay, so option will be mycetoma of the foot. Very right. So answer is mycetoma of the foot because mycetoma is having the discharging granules and sinuses. In the chromoplastomycosis, we had the cauliflower-like growth, but it is rough warty, and they might had mentioned that might be a copper penny bodies there. Now in the sporotrichosis, it is not because in the sporotrichosis we had a sporotrichoid type lesion along the lymphatics, and it is not a squamous cell carcinoma. A lady presents with the oral lacy ulcers with extension of the proximal nail fold to the nail bed. So the oral lacy ulcers like this, and one keyword and another keyword is the proximal nail fold is extending to the nail bed, and that is none other than pterygium. So this condition will be seen in a grade. It is in the lichen planus. Now why it is not a psoriasis? Because in the psoriasis we don't have an oral lesion and we don't have a pterygium. Why this is not a candidiasis? Because could be some oral candidiasis, but oral candidiasis mainly it is on the tongue and it is not associated with the nail changes. Pemphigus vulgaris, again pemphigus vulgaris we had oral changes but not the nail changes. So here the correct answer is lichen planus. A 60-year female presented with a pruritus, discharge and the black discoloration lesion on the private part. Now this was a little bit confusing question because what we thought that may not be the full question what we get, or there must be some other clue. As they say that lesion, it is appearing like a rough warty growth. Although this is quite extensive and it is not a pinkish color, it is a blackish color. Some may confuse it as a vulval carcinoma also. But as they say that this is having the pruritus, itching. So itching it is not seen in the carcinoma usually, and there is a discharge. So some could be a warty lesion, genital warts, which is becoming secondarily infected. So most we can say the favorable answer for this could be condyloma acuminata. Now it is not a condyloma lata because lata is a syphilis, and it is not an hemorrhoids because it is not coming through the anal cavity and it is around the vaginal orifice. And as I said that the vulval cancer we don't have usually the itching problem. Now the given condition of the nail is seen, and as you could see the nail is having the a spoon like appearance. So this is in iron deficiency anemia. Okay. Now the beefy red ulcer with the bipolar inclusion bodies. Beefy red ulcer and bipolar inclusion body, this is donovenosis. And donovenosis is a what? Granuloma inguinale. It is another name of adenomyosis, and this is caused by Klebsiella granulomatosis. So this is also known as granuloma inguinale. And if you now please listen carefully. Now, if you don't know that donovenosis is known as granuloma inguinale, now what I said that you have to go with the exclusion. Now, lymphogranuloma venereum, we know that not a donovenon bodies are seen, and it is not a beefy red floor. Chancroid may, again not a donovenon bodies, because it is having the granulomatous base with the undermined edge. Syphilitic chancre, again it is having the elevated edge, so it is none other than the donovenosis. So you may go that donovenosis might be known as the granuloma inguinale also. Clear? So correct answer is granuloma inguinale. You have to identify the lesion. As I said that there is a hyperpigmentary patch is seen, and you are seeing some blue light because it is the wood lamp examination going on. And as I said that the wood lamp examination, it is making the hyperpigmented patches prominent, like an ash leaf macule of the tuberous sclerosis in the vitiligo patch also. And here the vitiligo, it is in particular segment. So it is not a nevus of ITO, because it will be along with the supraclavicular. Now it is a vitiligo segmental. Yes, it could be the Baker's nevus. No, because in the Baker's nevus, hyperpigmentation with the hypertrichosis. And albinism, it is not an albinism because the hair are looking like black. So it is none other than segmental vitiligo. Clear? Now, nucleoside excision repair defect. We know that nucleoside excision repair defect, it is same called as the DNA repair defect what we had. And this is in a xeroderma pigmentosa, because melasma mein we had a hypersensitivity of these melanocytes to the sunlight. In the freckles, it is a genetic disorder of the more sensitivity, while in the lentigens there is a more of the melanocytes, while the nucleoside repair defect or the DNA repair defect is in xeroderma pigmentosa. So these were the questions they were asked in June exam. Now I'll see the few questions has been asked in the December exam. Now this was the question and the image. Now I'll give you another clue that whenever an image is given in the question, try to look at the image, because many times if you identify the image and try to look the last line of the question, look the options, and if we are able to get the answer, because in the around 80 to 90% of the cases you are able to get the answer with this step only, and there is no need to read the whole question, but yes, we have to read. So if you see the image, some papular rashes are seen on the hand and the body. This is what we can get. Now what will be the most probable diagnosis? Now still not much clue is there. Now viral exanthemas, yes, in the viral, but viral usually we don't have on the palm. Secondary syphilis, yes, in the secondary syphilis we had on the palm and the body. Now 10 it is out, toxic epidermal necrolysis, there is a peel off of her skin, that is also not there. The drug reaction, usually the drug reaction is also not looking like this. So we have to differentiate whether it's a viral lesions or the secondary syphilis. Now for that we have to read the question. Now the truck driver. Now, once they say the truck driver means something related to the STDs, because we know that truck drivers are away from the houses and there is a possibility that they can have a sexual contact with unhealthy individuals. So, the truck driver means something they are related to the STDs. And if I say I'm not going to read a whole question, I'll come to this probable diagnosis of secondary syphilis, but we cannot take a much risk. So, truck driver with the non-pruritic lesions all over the body, including palm and the oral ulcers after taking the medicine. So most probable diagnosis. Now here, as I said, that rest of the clues are not coming into that, except one more clue, that it is a non-pruritic lesion. Because usually in the viral exanthemas like in chickenpox, we had a itching is there. So this is again out. truck driver hair, non-pruritic lesions, and on the palm and the oral ulcers also. And we know that in the secondary syphilis we had a snail track ulcer, and in the chickenpox we don't had on the palm, and that's why all these are going in favor of the secondary syphilis. Okay, little bit difficult question, but you can correlate. Now identify the conditions shown in the image. Now we all know that this is the thick nose is there, along with some telangiectasia you could see on the malar area. Okay, so this is none other than a rhinophyma. We had a telangiectasia, and in the advanced stage of the these glands inflammation like a sebaceous gland, we are having this, that is rhinophyma. It is not a rosacea, because rosacea in an early stage we had a rhinophyma, and this is not an acne because we don't have an comedons. And rhinoscleroma, it is actually a malignant mass of the nasal area which is involving these septas and the bones also. So this is not a rhinoscleroma. So this is rhinophyma. Identify the image. Now you could see the image. It is appearing like a yellowish with some hyperkeratotic material is seen below the nail plate, and this is affecting the 2-3 nails. Nails are irregular, brittle, so most probably the fungal infection of the nail. Okay, why it is not a psoriatic nail? Because in the psoriatic nail, the nail plate, it is not appearing like a yellow friable. Okay, this is only the difference. So this is onychomycosis, yes, because this could be the fungal infection of the nail. Nail fold keratitis, no. Psoriasis, no. The yellow nail syndrome, no. So this is onychomycosis. Now if I say that what could be your next test to confirm the diagnosis, then your answer should be the 10% KOH mount, because in the 10% KOH mount we can see the fungal hyphae. Now this is again the image is given where we can see that sheets of the skin are peeled off, and this could be either in the toxic epidermal necrolysis or staphylococcal scalded skin syndrome. Now we have to see the history, and most probable diagnosis, if I say looking for the age, this appears to be a adult one. So staphylococcal scalded is commonly seen in the infants, so I am going more in favor of the 10. Now see the patient with a known case of the tuberculosis on medication presented with the given image. So it means the patient is taking some medicine, and because of this medicine the patient is having this manifestation, and this is none other than the toxic epidermal necrolysis. Now if we read the options, the Steve Johnson syndrome, that is also a part of this epidermal necrolysis. Now what is the difference? If we remember, we had discussed that the less than 10% of the body surface area is the Steve Johnson syndrome. More than 10%, 10 to 30% is an overlap, and more than 30% is 10. Now, if you could say that it is not only the 10%, the maximum area is involved. So it is not in a Steve Johnson syndrome, more in favor of the 10. Now, scrophulloderma, no, because here there must be the discharging sinuses, especially in the neck. Frick's drug eruptions, no, because there must be the erythematous plaque is there on the fixed area, and there is a generalized यहाँ पे peeling है. And here we had a pseudo-Nikolsky sign positive. Clear? Now, patient reported to the OPD with the lesion shown in the image. Now, this is a lesion. If you could see, it is this is the main lesion, and we are having the small satellite type of lesion. So satellite type of the lesion, if you can recall, it can be in the candidiasis also, it can be in the tuberculosis also. So they didn't mention the other features, whether the KOH mount is positive or the itching history is there. But if you see the option, they are all related to the tuberculosis. So now our one doubt is clear, that they are asking about the this leprosy. All options are different types of the leprosy, and we know that this satellite lesion is seen in the borderline tuberculoid type of leprosy. Okay. Now this is again hyperkeratotic patch is there in the nail. So identify this psoriatic nail. Now they had already given us that this is the nail of the psoriatic patient, not of the fungal infection. So identify the psoriatic nail change shown in the image. Salmon patch, it is not a salmon patch, because salmon patch was, if you can recall, it was a yellow patch on the nail plate. Okay, so this is not a salmon patch of the psoriasis. Auspitz sign, it is not, because it is a bleeding point after removing the scale, so this is also not there. Subungual hyperkeratosis, yes, this is the point. Cobnus phenomena, no, this is not a Cobnus phenomena. So this is subungual hyperkeratosis. Now identify the type of lepra reaction. Now if you could see here, the multiple erythematic lesions are there. So we know that in type 2 lepra reaction, the new erythematic lesions, they appear on the face. And type 1 may the existing lesion become erythematous, more of the nerve involvement. So most probably this image is of a type 2 lepra reaction. But this is because of what hypersensitivity? Type 3 hypersensitivity. And type 1 lepra reaction is because of type 4 hypersensitivity. Clear? This is again a swelling in the neck with some discharging pus or the caseating material. It is very difficult to say right now. So either some abscess or some tubercular lesion, because cervical lymph nodes are very common. So let us read. The most probable diagnosis, tubercular lymphadenitis, could be. Lymphoma may not be. Cellulitis, no, because it is not having like this localized. It is widespread. The brachial cyst, no. So even if I'm not reading the whole question, my answer will go with tubercular lymphadenitis. But still we'll see the patient is complaining of the swelling in the neck area for past 3 months. Because अगर acute abscess होता तो it will be suddenly for the few days, but it is for the 3 months, means there must be the cervical lymph nodes, and initially it was small and now it has been increasing. So now there must be the secondary bacterial infection, and because of that it is a little bit inflamed and having the discharge. So this is the tubercular lymphadenitis. Clear? Now identify the vitamin deficiency. We had just discussed that this is a Kessel-Neck appearance in the niacin, and niacin is none other than the vitamin B3. Identify this phenomena, and we had already discussed that here on scratching points we are having the appearance of the new lesions. This is the Cobnus phenomena. So dermographism mein, when you scratch, we may find edema and redness. Derriere sign mein, when we scratch on the skin patch or some abnormal skin. Auspitz sign, the bleeding points, but this is the Cobner phenomenon. This is again, we are having some nodularity, the Leone phase. So patient is having the no history of fever. So this is differentiating from the leishmaniasis. Okay. So patient is having the no history of the fever in the past. Now develop the nodular lesions of the face, identify the condition. Now post Kala-Jar dermal leishmaniasis, leprosy. So this could be the post, not post Kala-Jar, because there is no history of the fever. So this is out. Because in the post Kala-Jar we had the nodular lesions on the face and the hyperpigmented lesion on the chest. So this is out because no history of the fever. It could be a leprosy, yes. Cutaneous leishmaniasis, again no, because no history of fever. Erythema nodosum, it is not, because erythematous lesions are not there. So this is the leprosy. Okay. So these were the a few questions which were asked in the December 20 examination. Now the few more are asked in the August 2020. Auspitz sign seen in. Straightforward simple question. It is seen in pemphigus vulgaris? No. Psoriasis vulgaris? Yes. Pustular psoriasis? No. And discoid lupus erythematosus? No. So this is in psoriasis vulgaris. Now image, some ulcer and looking like a undermined edges, andar ghusa hua hai. Now read the options, the diagnosis: syphilis, tubercular lymph nodes, malignant and reactive. So see the image and look the options. So while looking the options, you will be focusing your thinking and the discussion with the given options only. अदरवाइज आपको ये पता ही नहीं चलेगा वो किस डिसीज के बारे में बात कर रहे हैं और किस ऑर्गन के बारे में बात कर रहे हैं। तो अगर आपने ऑप्शंस पढ़ लिए तो आपको ये पता चल जाएगा कि इस डिसीज के बारे में बात कर रहे हैं, इस ऑर्गन के बारे में बात कर रहे हैं। सो नाउ यू विल फोकस योर माइंड टू रिकलेक्ट द इंफॉर्मेशन. So it means some lymph node related to either the syphilis, tuberculosis. So syphilis में we don't had the cervical lymph node, so this is out. Tubercular lymph node, yes, it's the most common site with appearance undermined edge, most probable diagnosis. Now malignant lymph nodes, again not. Reactive lymphadenopathy may not be there. Now we'll see the answer with the undermined edge. हमारा काम ही उसने पूरा कर दिया एग्जामिनर ने. Undermined edge, no need to go anywhere. We know that undermined edge ulcers is seen in tuberculosis, chancroid, and pyoderma. Chancroid will be on the genitalia, so this is out. And pyoderma is on the leg, again out. So they are saying that undermined edge ulcer is on the neck, so definitely it will be your tubercular lymph node enlargement. Now again, seen the image just now, erythematous lesions around the orificial cavities, and this is seen in the zinc deficiency. Acrodermatitis enteropathica. Now this is again the comedons, black or white comedons. You can see these are the black comedons or blackheads. So the question is that a first line treatment for the acne comedons. Now it means they are asking that it is the grade 1 stage when we had only the acne comedons, and we know that grade 1 acne comedons only the topical retinoids are given. Now grade 2 when papules are there we are giving the topical antibiotics also. Grade 3 when we had a pustule we are giving the systemic antibiotics or the benzyl peroxides, and in the grade 4 when nodulocystic we are giving the topical steroids, that is isotretinoin. So this is what we had discussed just now. A tumor of a multiple color must be a melanoma, and you could see that it is very unhealthy appearance with the irregular margins, little bit of bigger size, the multiple colors, dark color, little bit light colors are there. So this is none other than the malignant melanoma. So identify the condition shown means, so first we'll see the option basal cell carcinoma, malignant melanoma. So they're asking something tumor of the skin. So this is not a basal cell carcinoma because some pigmentations are seen. The malignant melanoma, yes, this could be the possibility. Squamous cell carcinoma, again not, because that must be the everted edges. And nevus, it is not because it is not a benign, it is appearing as a malignant. So it is a malignant melanoma. Okay. So this is some inflammatory lesions are there, although with the image it appears to be something erythematous, but it is not very clear. Now they are saying which organism is causing erysipelas. So they had given us a diagnosis that this is erysipelas, and erysipelas, we know that it is the inflammation of the dermis, and further it is going down, then it becomes a cellulitis. It is localized with a well-defined margin, and this is mainly caused because of streptococci. So the erysipelas as well as the cellulitis is the most important organism is streptococci. Although this question you can say that it's a surgery question, because here there was a horn was given, and the question was the cutaneous horn as shown in the image is associated. So the cutaneous horn is usually associated with the squamous cell carcinoma. Again, we can see the rough warty lesions around the anal area, and this is appearing to be genital warts or condyloma acuminata. Now let me see the options. Now identify the condition. Condyloma acuminata looks like that. Bowens disease, no, this is some skin manifestations on the external body surface we are having, and we don't have these warty spike-like lesions. It is not a condyloma lata because lata is in the secondary syphilis. We don't have a rough lesion. We had a moist, soft lesions are there, and it is not an hemorrhoids, because in the hemorrhoids you may find that the lesion are coming from the anal cavity. The tags are there, but this is around the anal cavity. So this is your condyloma acuminata. Now, repeatedly they are asking the condyloma acuminata and lata, so no confusion should be there. So this is again the same what we had, the ulcer on the leg with looking like some undermined edges. Let us see. The patient is suffering from ulcerative colitis. They had given us a clue that patient is suffering with the ulcerative colitis, means the intestinal manifestation, inflammatory bowel disease, and with the ulcer on the anterior leg. So none other than it is the pyoderma gangrenosum. This is again a very commonly asked image, is the golden yellow color crust in the non-bullous impetigo or the impetigo contagiosa. So now here let me see, the question is the common complication. Now they are not asking the agent, they are not asking the disease, they say that complication. So first we have to identify the lesion, and then we have to think that what complication can be there. So this is a non-bullous impetigo, and we know that it is caused because of the streptococci, and the streptococcus we had the post-streptococcal glomerulonephritis, because staphylococcal scalded disc syndrome is because of the staphylococci, and this is seen in the bullous impetigo. Okay, and encephalitis and pneumonitis is different. Then here again you are seeing that a pus collection is seen in the nail fold, so this is none other than the acute paronychia. Okay, so the if you see the options, the psoriasis, no. Paronychia, yes. Alopecia areata, there must be the trichomoniasia, no. Yellow nail syndrome, no. So a 30-year-old male complains of the pain in the fingernail. On examination, there is a red nail with the pus. So this is your paronychia. Now here you could see that some skin freckling is there, and badi डरावनी सी freckling लग रही है. Extensive skin damage is there. So let me see something related to either the freckling or the xeroderma pigmentosa. Now let me see that patient is having the history of the severe sunburn after 5 minutes of an exposure. Within 5 minutes, extensive sunburns are there, freckling in the sun exposed area, and skin pigmentation. So diagnosis is warts, nowhere. Melanocyte nevus, no way. The xeroderma pigmentosa, yes, this is the possibility and not the Bloom syndrome. So this is a xeroderma pigmentosa. Now another is again the very common image. As I said, that the rashes are seen on the hand, on the foot, and the mouth. When all these combinations are there, it is hand, foot, mouth disease caused by the Coxsackie A16 virus. So child present with the sores in the mouth, hand, and foot, the causative organism is. It is the Coxsackie A16. Because the pox virus, it is causing the fifth disease, that is erythema infectiosum, and leading to the slap-cheeked appearance. And herpes virus, it is causing the herpes simplex infections, and human papillomavirus is causing the genital warts. Now here the rashes are pleomorphic rashes, ulcers, blisters, and papules. So they say the child with the fever and pleomorphic rash. So measles mein we don't had the these blisters or the ulcers. The smallpox, we don't had a pleomorphic. We had a single type of the rashes there. So this is a chicken pox. Okay. So these were a few questions which were asked in the last June examination. So you could see that if you know the content, you can apply the differential diagnosis, then you can very well answer these questions. Okay. So with these words, I think we can wind up the session. And now you had a whole evening, you just relax and you can utilize this time for revising your content. And you all had my number, and anytime if you had any problem, any difficulty, you can message me. Now Avan is saying that, madam, please revise the images. Now dear, we will have a separate session where I'll be discussing the whole images of the different topics at one place only. Okay, so no problem. We'll be discussing the images again, and although all the images are there in your study material, but at one place I'll be discussing all the images and their relevant points, so don't worry. So okay, any doubt, any query? Do you want to ask the repeat PSM classes? I think we don't have a schedule right now. Maybe within a week or 10 days, will be starting the repeat PSM classes. Okay, so I don't think any further doubt query. So with these words, I can end this session and wishing you all the very best. I know आप लोग बहुत अच्छे से पढ़ाई कर रहे हो, बहुत अच्छे से मेहनत कर रहे हो, बस इसी तरह से लगे रहना और ब्रॉड माइंडेड होके स्टडी करना. Try to correlate the concepts and try to remember the important points. Try to identify the keywords in the question and make the correct answer of the question. Give each and every test whatever we are having till your exams, and as I said that always try to analyze. किसी से कंपेयर नहीं करना कि मेरे फ्रेंड के 70 मार्क्स आए या मेरे फ्रेंड के 90 मार्क्स आए, मेरे जो है वो 65 मार्क्स आए या मेरे 80 मार्क्स आए. नो, नेवर कंपेयर विथ एनी बडी. कि मोस्टली क्या होता है कि दो फ्रेंड जब साथ में बैठ के स्टडी करते हैं ना और एक फ्रेंड के कम आते हैं दूसरे के ज़्यादा आते हैं, तो वहीं पे प्रॉब्लम शुरू हो जाता है कि यार पढ़ा तो दोनों ने साथ में था, उसके ज़्यादा कैसे आ गए या उसके कम कैसे आ गए. नो प्रॉब्लम. Never compare yourself with other one, okay, because you are a unique creature of the God. You are not the same as other one. हो सकता है you may not be able to recall, or you might not be feeling very happy at that particular moment. You might not slept properly, because of that you were not able to focus. There could be the so many factors could be there. So never compare with anyone else, and focus on your studies, focus on your mission, and just focus on your future life. Or what is I can say that do your best, do the hard work, and leave everything on the God. नेवर थिंक फॉर द रिजल्ट. कर्मा करते जाओ, फल की चिंता मत करो. अगर आपने अच्छा कर्म किए हैं तो फल बिल्कुल अच्छा होगा. ओके, सो बाय बाय, टेक केयर, विशिंग यू ऑल द वेरी बेस्ट.